Hello everyone. Welcome to this global classroom. I am Dr. Philip Thomas. I'm a general surgeon specialized in liver, biliary, pancreatic, and organ transplant surgery. The topic that I will be discussing with you today is acute pancreatitis. You can see that I've had a long journey in medical education. It started in India, where I did my basic training and where I also taught general surgery for a long time. I now live in the US and I have been teaching general surgery to medical students and residents at the University of Texas in Galveston and most recently in the Rio Grande Valley. What are the objectives of this lecture? First of all, I want to make you confident in the clinical diagnosis and the management of acute pancreatitis. I want you to be familiar with the CT scan appearance of acute pancreatitis and how to read a pancreas CT scan. And lastly, I want you to know or be familiar with the step-up approach to interventional management and surgical management of the subsection of patients or the smaller percentage of patients that go on to requiring surgery. Now, I realize that for most of you, the main concern is examinations. From my experience, and I have taken a lot of examinations on my own, I find that the best preparation for examinations is when you collaborate. The collaboration between learners. And so I would encourage you to think of questions as I go through this talk and either post them below or email them to me so that we can discuss these questions. And there is a cash prize for the best questions, and I will tell you more about this by the end of this talk. Anybody can make a diagnosis of acute pancreatitis. In fact, most of the time, it is a triage nurse in the emergency room or a junior doctor in the setup at the emergency room that makes the diagnosis. All that you need really is the elevation of serum amylase to say that this is acute pancreatitis. Usually we like to cross-check with the serum lipase because it has a longer half-life, doesn't disappear from the serum that quickly, and it will tell you that this was indeed a true elevation of the amylase from the pancreas. There are a few conditions in which the amylase level may be elevated without it being acute pancreatitis. You have to remember that the serum amylase is merely a reflection of the amylase that has leaked out from where it is supposed to be within the duodenum and is being absorbed into the bloodstream. And so a perforated duodenal ulcer, usually because it's a peptic ulcer perforation, or mesenteric ischemia can result in an elevated serum amylase. And it's a good idea to keep this in the differential diagnosis and think about this as you go along with the patient. So what is the role of the doctor in diagnosis? There are essentially two things. One is you have to assess the severity, and the second, to determine the etiology of pancreatitis. This is something that generally is the function required when a surgical consultation is sent in a patient with acute pancreatitis. Touching on assessing severity, the two severity scoring systems that have been hallowed with time are the Ranson's and the Apache. Apache is an acronym for Acute Physiology and Chronic Health Evaluation. So there are a lot of variables that go into making the Apache score. Ranson's has fewer criteria, but you really need two sets of recordings at 0 and 48 hours before you can assign a Ranson score. So this is an important limitation of the Ranson score. The BISAP score is something that has become more popular recently, and I will touch on this shortly. I want you to notice here that there is no mention of imaging findings in severity assessment. Imaging is, however, an important tool that we have in assessing etiology. So this is something to remember. Assessment of severity is clinical, along with certain clinical bedside observations like your pulse oximeter, the state of the lungs, respiratory rate, blood gases, renal function, etc., but not the imaging. The imaging is important later, at a later point, when you're really thinking about etiology. Why do you think this is the case? Severity assessment is key to initial management. It is not really that important to plan surgery in a patient with acute pancreatitis, and consequently the imaging and even the clinical examination of the abdomen does not have as much importance. This is probably reflected in the fact that residents in America are often told, eat while you can, sleep while you can, but don't mess with the pancreas. In other words, be careful before you take this kind of a patient to surgery based on what you're seeing on clinical examination of the abdomen. I'm also reminded of my early days when I would be reading obstetrics and gynecology, and the book that we used at the time had one phrase which I still remember in the management of labor. And the line was, masterly inactivity and watchful expectancy. That could summarize the way to manage a patient with acute pancreatitis. So let's go on to a patient who presented recently to me, which will illustrate some of these points that I have made in the previous slides. This was a 47-year-old male. He presented with acute abdominal pain. He had been seen in an emergency room, which is a standalone facility at an outside place, and they had done immediately a CT scan of the abdomen, and they had done some blood tests, and they referred him for management of acute necrotizing pancreatitis. This is one of the most severe form of acute pancreatitis. The patient was very clear that he had the first onset of his symptoms hardly 6 hours earlier. And the reason he was so sure was that he had actually had a similar episode 5 years ago when he required to be admitted in hospital for a week, and they had not determined the etiology of his acute pancreatitis. And I told him that you need to stop drinking alcohol, which he said that he had been very faithfully abstinent about. His serum lipase at the time of referral was very high. It was over 3,000 international units per liter. Bedside assessment of the severity of this patient's acute pancreatitis, I elected to use the BISAP or the BISAP score. Now, the B is for BUN. It was not available when I was seeing the patient. The last letter P is for pleural effusion, and the chest X-ray wasn't available when I was seeing the patient. So I had to assess the intervening three variables, which is impaired mental status, SIRS, and age over 60. And for each of these, I gave him a 0 score because he was mentating well. He had no tachycardia, hypotension, or fever, and his age was below 60. So right there, I know that I have a score of less than 3 over 5. As it turned out, even the BUN was not elevated, and he had no pleural effusion. So his BISAP score was essentially 0. If the score is over 3 by 5 or closer to 5 on 5, then you know you're dealing with an acute pancreatitis situation, and you can do a more detailed scoring by either the Ranson or the Apache, which, as I mentioned, needs a lot more of evaluation of each organ system. Now, I knew that I had a disconnect between what the radiologist had reported as acute necrotizing pancreatitis and the clinical severity assessment at the bedside. I haven't told you anything about the abdominal examination of this patient. Abdominal examination is not part of the scoring system for severity assessment. Is it not important? Or could it be misleading? Well, those are the points which we need to think about. But the fact is that in this patient, he had minimal guarding in the upper abdomen. The percussion note was tympanitic, and because I was not sure whether he had an acute gastric dilatation or a colonic dilatation, which was giving rise to the tympanitic note, I ordered a KUB. As it turned out, he had a large stomach. We put in an NG tube that immediately relieved a lot of his abdominal pain and almost all his nausea. The immediate management in this patient was to start IV fluids, prepare for a central line insertion so that we could monitor CVP if we needed to. I elected not to put in a Foley catheter to continuously monitor his volume status. Putting on a pulse ox was easy. We got a chest x-ray and a KUB as I had mentioned, put in an NG tube and set blood for a lipid profile. By this time, we had the CDs of the CT scan done at the outside emergency room, and we ran it through our system to look at the CT scans and see what was it that had made the radiologist report this patient as an acute necrotizing pancreatitis. This is the first of the CT scan reports that I'm going to show you. And as you can see, this is a CT scan of the abdomen. You can see the superior mesenteric artery. You can see the superior mesenteric vein, which is going just under the neck of the pancreas. And above the neck of the pancreas, you can see an arterial structure opacified by the dye, which is the hepatic artery and the gastroduodenal artery. So it is immediately evident in this patient that this scan is not a typical pancreas protocol CT scan. This is a general CT scan of the abdomen, which they took at the emergency room. For a pancreas protocol CT scan, you need 3 phases. You need the phase, which is initial, like a screening, which does not have any dye. Then you have to give a bolus of dye and shoot the images in a timed manner so that you get an arterial phase and a venous phase. So this was just a general CT scan, and you can see in the CT scan why it is that the radiologist thought there was necrotizing pancreatitis, because there is an area in the head of the pancreas which is not as well opacified as the rest of the pancreas. This is another view of the CT scans that were sent. Here again, you see vascular structures in the vicinity of the pancreas. However, most of these structures are venous. You can see the portal vein forming behind the neck of the pancreas. And once again, there is an area of the head of the pancreas that doesn't opacify as well as the rest of the pancreas. Look at this, however. In this slide, you can see that the opacification of the portal vein is seen a little better. It is seen closer to the liver. And in this image, you can see that the head of the pancreas is completely opacified. So probably the opacification of the pancreas with the contrast has gone through a dynamic phase, and it is not a fixed area of necrosis within the pancreas. At this point, we can quickly revise the anatomy of the pancreas. As you know, the pancreas is a dual organ. There is an exocrine function and there is an endocrine function. So these are 2 distinct parts of the pancreas, but the endocrine function is mediated through the islets, which are distributed right through the pancreas. So when we are talking about acute pancreatitis, it's all in connection with the exocrine function of the pancreas. You have the head of the pancreas, which is seated within the loop, or so-called C loop of the duodenum. The head of the pancreas is supplied from above by the gastroduodenal artery and from below by the superior mesenteric artery. After the head, you have the neck of the pancreas as you move from right to left. The neck is very clear structure because you can see the formation of the portal vein behind the neck of the pancreas. You can sometimes see the confluence of the splenic vein and the superior mesenteric vein, which join to form the portal vein behind the neck of the pancreas. The body of the pancreas is that part which lies anterior to the spine. The splenic artery runs along its upper border. The splenic vein runs along the lower border. The splenic artery runs from right to left, the splenic vein from left to the right. The tail of the pancreas is a small part of the pancreas which is very close to the hilum of the spleen. This is the only part of the pancreas which is intraperitoneal. The bile duct, which is formed in the liver by the confluence of the right and the left bile ducts, travels down as the common hepatic duct, then the common bile duct, and enters the head of the pancreas, where it then runs towards the mid part of the duodenum or the middle of the second part of the duodenum and opens into the duodenum through the ampulla. It's important to remember this anatomy because this is important for gallstone pancreatitis. As I had mentioned earlier, imaging findings are important to decide etiology, not the severity, but the etiology. So what was the etiology of the pancreatitis in this patient? The important negative finding on the CT is that there is no dilatation of the bile duct. In other words, there is no obstruction to the lower end of the bile duct at the level of the ampulla from a gallstone. There is also no evidence of gallstones or sludge in the gallbladder seen on the CT scan. It is important to note, however, that sometimes this can be misleading. A better test to determine whether there are stones in the gallbladder is the ultrasound. Gallstones from the gallbladder traveling through the cystic duct into the common bile duct, coming down the common bile duct, getting impacted at the ampulla of Vater, and causing back pressure into the pancreatic duct, causing the pancreatic duct to get dilated, and perhaps the early activation of the enzymes within the pancreatic duct has not happened in this patient. The other thing to decide in this patient is, does he have chronic pancreatitis? After all, he did have an episode of acute pancreatitis pain 5 years earlier. This is also something that you can see in the CT scan. When we use the term acute, it can mean of short duration, recent onset, a very exacerbated course, which is all part of the term acute. But when you look at it in another way, we use the word acute when we know that this condition will recover to normal. And this patient had a 5-year period of normality. The word chronic is used when there is more indolent, long-term, chronic kind of symptom presentation. But the term chronic means that there is fibrosis. Fibrosis in the pancreas can be seen on the CT scan as shrinking of the pancreas substance and dilatation of the pancreatic duct. Those two features are not seen in this patient, so we can be fairly confident that there is no evidence of chronic pancreatitis in this patient, and what he has had is a recurrent acute attack. So to reiterate, what are the findings against chronic pancreatitis in this patient? 1, clinically, he has not had any weight loss, there has been no malabsorption, there is no loss of exocrine function in this patient. In the 5 years that have lapsed from the time he had his first attack to now. On imaging, there is no loss of pancreatic tissue, there is no fibrosis, there is no ductal dilatation, and there are no stones seen in the pancreas. So we can be fairly confident that this patient has an acute pancreatitis now and not just an exacerbation of chronic pancreatitis. The definition of acute pancreatitis is duct or acinar injury in the exocrine pancreas by a direct or indirect mechanism leading to activation of the pancreatic juice, which then results in inflammation and autodigestion of the pancreas and surrounding tissues in the retroperitoneum, because pancreatic juice can leak out of the ductal system into the retroperitoneum. So, in the immediate management of this patient, in counseling the patient and his family members, we have good news and bad news. The good news is that this pancreas can be expected to recover to normal once again, like it did 5 years ago. The bad news is he can get very, very sick before that actually happens. The acute pancreatitis illness has a lot of systemic component, and we don't know at this point whether it's going to go in that route or not. The good news is he does not need any endoscopic or surgical management right away. The bad news is there's not much we can do to abort this attack of acute pancreatitis, and we have just got to wait and watch and see which way the patient goes. As it happened in this patient, his course in hospital was very benign. He was in ICU for a couple of days. He needed some IV fluids. We had him on NG tube suction for a day. after which his abdominal pain had been very well relieved. So we started him on early enteral feeding, and he tolerated this well. Pain control is usually done with narcotics. The favorite drug here is Dilaudid, which is a hydroxymorphine. And for nausea control, we use the ondansetron, which is available universally. While monitoring him, he did not develop any organ dysfunction over the course of his brief hospital stay. The question really is, what was the etiology of this acute pancreatitis? He denied alcohol. There are no gallstones. There's no sludge in the gallbladder. And there is no elevation of his triglycerides. So let's go now into a more theoretical discussion about etiology of acute pancreatitis. When thinking about the etiology of acute pancreatitis, it is important to remember that about 40% of the cases are caused by gallstones. In other words, when I'm going to see a patient, I can literally flip a coin and I'll be correct 50% of the time, nearly 50% of the time, that this is going to be due to gallstones. What is the importance of focusing on gallstones? It is because this is the only situation in acute pancreatitis where we can do something to abort the attack. And the treatment really is endoscopic retrograde cholangiopancreatography, which is also called ERCP, to be done within 24 hours of the patient's admission or onset of symptoms, because if we do a sphincterotomy, open up the ampulla, remove the gallstones which are obstructing the lower end of the common bile duct, this attack of acute pancreatitis can be aborted, and all that remains is to remove the patient's gallbladder, usually by a laparoscopic cholecystectomy before he is discharged, and that's the end of that. The important thing is early ERCP. Now, how is it that this is not such a simple decision, or is it a simple decision? It is actually not a simple decision. For a long time, there was controversy about whether patients in acute pancreatitis should be subjected to ERCP. When you go into the history of ERCP, it was first done in the early 1960s by a British gastroenterologist called Peter Cotton, and the scopes were not really well designed at the time. You need a side viewing scope which goes into the second part of the duodenum and then is able to look at the ampulla end on. Then you have to introduce a wire or a tube into the ampulla. Now, the pancreatic duct is in a straight line, so the tendency of the tube is to go into the pancreatic duct. This can be a potential disaster in a patient with acute pancreatic inflammation. So the ERCP endoscopist has to be able to lift the tip of the tube and send it back upwards into the bile duct. That is when it is safe to do a sphincterotomy and open up the bile duct. Over the years, optics have become better, people have become better trained, and it is possible to do a safe ERCP for an acute pancreatitis patient. However, it's important to remember that you require general anesthesia. You have to keep the patient prone, so there may be a risk of aspiration and desaturation during the procedure being done in the endoscopy suite, and you have to have fluoroscopy at the time of endoscopy, and lastly, you have to have a very good endoscopist. So if all of these conditions can be met, then yes, doing an ERCP early in a patient where gallstone pancreatitis is diagnosed or has a high index of suspicion is a very good way to manage an acute pancreatitis. And this will be possible or may be required in up to 40% of all the patients. The next most common cause of acute pancreatitis is alcohol. So between gallstones and alcohol, you account for 70% of patients with acute pancreatitis. The pattern of alcohol is important to establish. Usually, there'll be 4 to 5 years history of alcohol intake in a patient, and the pattern of alcohol is usually one of binge drinking. In other words, weekend, a lot of alcohol, a lot of good food, and that's the kind of pattern that results in acute pancreatitis, as opposed to cirrhosis of the liver, which is a more daily, morning to evening kind of consumption pattern. I always tell everybody that remember, alcohol can be a red herring. There may be something else that is really responsible for the acute pancreatitis, and it's easy for us to blame the patient and blame the fact that he's taking alcohol. What's the problem with that? Well, he'll stop taking alcohol, like this patient did, and he'll come back with acute pancreatitis. We still have 30% of all the patients that present with acute pancreatitis to account for. 1 in 3 will have neither alcohol nor gallstone pancreatitis. It may be different from region to region, but we have to recognize that globally, obesity is becoming a problem. So the next most common etiology to look for is hypertriglyceridemia. And this is particularly important in somebody who is overweight. And in my experience, I always look for this in females who are obese, who have no gallstones, and this combination is usually seen in younger women. You can get hypertriglyceridemia as a cause of acute pancreatitis in teenagers and in the early 20s. The next thing to look at is the serum calcium. Hypercalcemia can cause acute pancreatitis. If the calcium level is normal in a patient, you got to think whether it was actually high, because typically in acute pancreatitis, due to widespread saponification within the abdomen, calcium levels tend to be on the lower side. So a normal or elevated calcium level should immediately catch your attention. Follow it up with checking a parathyroid hormone level and looking for the parathyroid gland enlargement or a parathyroid tumor. The next most common cause of acute pancreatitis is trauma. And trauma can be iatrogenic or can be due to some random accident. I've already touched on ERCP-related injury to the pancreatic duct, which can happen in a patient who is subjected to ERCP in a less than ideal situation, and a pancreatic intubation and elevation of the pressure within the pancreatic duct can create an acute pancreatitis. Fortunately, these tend to be self-limiting. Blunt abdominal injury is also a cause of acute pancreatitis. Usually this is a seatbelt or a very powerful blow to the abdomen like you would get in a karate kick, and this causes the pancreatic body to flex over the spine and it ruptures the pancreatic duct. These patients will have severe pain. It goes away after some time and they may present with a large pseudocyst of the pancreas at a later point. As the population gets older, we tend to see more and more elderly patients in their late 70s and 80s who will present to the ICU with something else, maybe something cardiac, maybe some other fracture or something else, and they can be found to have acute pancreatitis in the hospital. And the etiology of this is ischemia. Following shock and hypotension, we know that the splanchnic circulation is reduced in a protective mechanism by the body to selectively perfuse the more important organs, the heart and the brain. This reduction in splanchnic blood flow can result in ischemia of the pancreas, and this is particularly likely to happen in an older patient whose celiac artery or the superior mesenteric artery at the ostium is narrowed by the presence of a plaque. Remember, the pancreas does not have any artery exclusively supplying it. It is supplied by side branches of arteries which are heading someplace else, either to the duodenum or to the spleen or to the small bowel. So these small branches can get thrombosed or have a very low flow situation, resulting in ischemia of the pancreas and an acute pancreatitis, even necrotizing pancreatitis as a result. The next most common thing to think about is acute pancreatitis following some medication. In my practice of transplant surgery, we worry about steroids. Steroids can cause acute pancreatitis. And another fairly typical presentation is a patient who has severe rheumatoid arthritis who is on steroids presenting with acute pancreatitis. The problem is then you have to figure out whether you can stop the drug or not. And this is sometimes a tricky decision to be taken. Anti-cancer drugs can cause acute pancreatitis. And as it happened in this patient, the only etiology we could determine was that he was taking a medication to lose weight. And this is the new medication, which is now the rage all over the world. Ozempic is the one that he was taking, and we had to stop that while his pancreatitis recovered. Lastly, immune suppression drugs can cause acute pancreatitis, but an autoimmune pancreatitis is also now sometimes seen. Usually the pancreas is edematous and large, and you have to diagnose this by sending off immunoglobulins, and the IgG4 is the diagnostic marker of autoimmune pancreatitis. The last category to think of in etiology of pancreatitis is infections and infestations. There are areas where roundworm infestation is endemic, and these roundworms can get into the ampulla and block the bile duct in a mechanism very similar to gallstone disease and require to be extracted, usually nowadays by ERCP, but in former times we would have to actually operate and remove we would have to operate and actually remove the roundworms from the bile duct via a duodenotomy of the second part of the duodenum. There are several viruses that can cause acute pancreatitis, and these are commonly seen in children. They are Coxsackie and mumps viruses, most commonly associated with acute pancreatitis. Moving on to surgical management of acute pancreatitis. It is important to remember that this is required only in complications of acute pancreatitis, with the sole exception of gallstones, which we have discussed earlier. The complication which usually requires surgery is a peripancreatic fluid collection. And these fluid collections can be of different types. A pseudocyst is the commonest one and occurs very frequently. In our patient, in the CT scan, you could see peripancreatic fluid collections. These were probably pseudocysts. What is a pseudocyst? A pseudocyst is a collection of pancreatic juice outside the pancreas. It is usually limited by the reaction of the body, which tends to limit it, and it usually has a benign course. Most of them get absorbed on their own. Some of them require to be treated, and these are usually the larger ones that are more than 10 centimeters in diameter. So the principle is the step-up approach. The first step is watchful expectancy and masterly inactivity. Wait. The longer you can wait after the day of onset or after the date of onset, the more likely you are to achieve a good outcome. Watch if the pancreatic fluid collection is not going away and is still symptomatic. You may have to drain it, and there are ways of draining it either percutaneously or via endoscopy. Advanced endoscopy can drain collections through the stomach. So pseudocyst drainage, walled-off pancreatic necrosis drainage, and waiting to do this by either endoscopy or interventional radiology, preferably for 3 to 4 weeks, is the best approach to managing these collections. Management of mesenteric vein thrombosis will require anticoagulation. If there's evidence of gangrene of the bowel, that will require usually open surgery. Rarely, a very extensive necrosis can happen in the retroperitoneum that is very difficult to manage by minimally invasive methods, and in those patients you have to do a laparotomy, evacuate all the necrotic tissue, and sometimes keep a laparostoma or a device that can permit going back in multiple times until all the necrotic tissue has been completely removed. Again, the longer you can wait to do these kind of interventions, the more likely you are to get a good outcome. So in conclusion, understanding and managing acute pancreatitis is important because, as you can see, you require a multidisciplinary approach to pancreatitis. You need ICU people, you need interventional radiologists, advanced endoscopy, and surgery to complete the management of a very severe acute pancreatitis patient. All of these patients require to be carefully monitored in the ICU, initial management to resuscitate them, and imaging to document the etiology. Once you have a walled-off pancreatic necrosis, you have to wait, keep the patient under observation, and sometimes CT scans will have to be done weekly until they are finally resolved. As I had mentioned at the beginning of this talk, I would address exam preparation at the end. In preparing for an examination, you have a choice. You can either compete with everybody else or you can collaborate with everybody else. And I believe, from my experience and whatever I have seen, collaboration is much better than competition. Collaboration usually means that you have to encourage the other learners and not just be a passive spectator. You have to generate questions, whether they're from your own thinking, your own understanding, or whether they're from a question bank which you have been going through and you have encountered a question which you think is difficult. Remember that questions which have stumped you are potentially a high-value question. And the highest value question is a question that stumps the examiner or the professor as well. So as you go through these, you can find these questions, enter them in this video at the end, or send them to me by email, and we will have cash prizes of $25, $50, and maybe even $100 for the high value questions, which will help you to, the idea of the cash prize is to help you and stimulate you to collaborate rather than to compete as you go through this. To paraphrase the old African proverb, travel together in order to travel long, and keep in touch.